Hello, this is Mohammed Mubashir Uddin Ahmed. Today in this video we are gonna examine the abdomen. So let's begin our video with the intro of the patient and his details. Abdominal examination begins with inspection. Abnormalities such as distension, scars, stretch marks, hematomas, and elongated veins can provide the first evidence for condition involving the abdomen. The abdomen can be separated into individual regions to more precisely depict anatomical location. A classical distribution consists of four quadrants that are separated right from left by a single vertical plane and superior from inferior by a horizontal plane. Another common scheme divides the anterior abdominal wall into 9 anatomical regions as part of this distribution. The upper and lower abdomen are separated into thirds. These regions enable more specific findings during examination. In contrast, to examine the chest, auscultation of the abdomen should occur before palpation. Otherwise, stimulation of the bowel may trigger a false increase in peristalsis. Bowel sounds are physiologically heard as clicks and gurgles in an irregular pattern. Hyperactive or absent sound can indicate a paralytic ileus resulting postoperatively or from a condition like peritonitis. Hyperactive sounds may indicate gastrointestinal infection or trying to overcome obstructions which could imply a mechanical ileus. Beside bowel sounds, an aortic bruit due to an aneurysm or stenosis may be auscultate it at the upper umbilical area. Listen for possible renal artery bruits bilaterally from this area. Assessing precaution sounds is helpful in determining the size, position, and density of abdominal count. Solid organs, fluids, or tumors leads to dull sounds that may sound similar to precaution sounds of the thigh. In contrast, the precaution sounds of the hollow air find filled intestines in more drum-like in nature and in therefore known as tympanic or tympanic. Tympanic sounds are even more extreme in condition, including the auscultation of excess gas within the bowel as seen in abdominal bloating. A distended abdomen has various causes, including adiposity, bloating, a tumor, or ascites. In addition to precaution, being able to form a belly fold may help in determining the cause physiologically. The examinee should be able to form a small belly fold. In contrast, in patients with the massive ascites, it would be difficult or not possible to do so. The most reliable clinical sign to detect ascites is checking for shifting dullness. If a patient with ascites is lying, spine fluid accumulates in the flank, regions leading to dullness or precautions at the same time. The air-filled bowel loops are forced upwards by the free fluid due to buoyancy, resulting in tympanic precaution. To locate specifically where dullness shifts to the tympani or the air fluid level, precaution should be performed from side towards the middle to confirm the dullness is caused by ascites. Ask the patient to switch a lateral distributed position. If ascites is present in the air-filled bowel, loops will shift accordingly and remain at the surface of the fluid. As a result, the air fluid level will shift as well. This is known as shifting dullness. Palpation should be conducted last. It can be uncomfortable for some patients, causing them to tense up. To help relax the abdominal muscle, you can try distracting patient with conversation or asking them to breathe deeply to prevent the patient from tightening the abdominal muscle, otherwise known as guiding. It is important to begin palpating at a point far from any painful areas and to avoid using cold hands. Begin by swallowing, palpating the surface. Doing so may already elect involuntary guiding. Take any note of pressure pain, rebound tenderness, or abdominal masses. Palpating a normal sized liver is sometimes difficult as it usually extends beyond the ribcage in the area of the right mid-clavicular lane and transverse epigastric region. Even in this area, the liver can only felt through deep palpation. Liver can extend as far as the lower abdomen. Palpation should start from further down in the right lower quadrant. If necessary, by manual palpation can help locate the liver. Another possibility to determine the size of the liver is Scar's test. Although its reliability and precision remain controversial, one method is to place the stethoscope on the chest just below the xiphoid process. Lightly scratch the abdominal skin in the right lower quadrant with a finger nail parallel to the expected liver border. The air-filled bowel loops under the fingertips poorly transmitted the sound wave to stethoscope. Proceed with the scratch test by gradually moving examinally towards the rib cage and transformation from bowel to liver tissue. Sound waves can travel more intensely in notable for a sudden increase in loudness of scratching. Assess the gallbladder next, which should only be palpable in pathological state. For example, if hydrop is present, palpation takes place somewhat medial to the mid-clavicular line below the right rib cage. Evaluating for tenderness or palpation is important, since it may indicate chlorhydrosis. Cholelithitis can also be evaluated by testing for a positive Murphy's sign. To test the sign, the first ask the patient to exhale while palpating the gallbladder area medial to mid-clavicular lane. The spleen is generally not palpable in healthy adults. A pathological enlarged spleen is palpated under the left costal margin during inspiration, as per inferior edges descend to the examiner's fingertips. If an enlarged spleen is already suspected, palpation should begin further down. The examination may be palpated by gently lifting the left flank of the patient vertically.